Good afternoon. My name is Richardson. Thank you so much for inviting me here today. My presentation is a bit different because it's not tech, but it's based on a transformational model that we're doing in health systems today and medical group practices. The topic is systems-based transformation leadership solutions, and it is a bottoms-up approach versus a top-down approach, and it's based on the new agreements in healthcare developed by David Dibble. David is an expert on systems-based transformation, and in early 2000s switched into a focus on healthcare leadership transformation. So the 94% rule for the quality guru Deming basically says this, that 94% of the results being created in the workplace are a function of the systems in which people work and not the efforts of the people. And I start off by this because my background, I have 25 plus years of healthcare administration experience in leadership operations. Early in my career, I started off, I was an administrative director for anesthesiology for 9 years. And in order for me to fully understand the flows of medicine and understand, in order to advocate for capital equipment, advocate for the physicians, the CRNAs, the nurses, and so forth, and just in terms of workplace development, I quickly learned that the best place for me to learn that was to go to where the care was provided. I also was in a large academic medical center, so that meant I spent a lot of time in the operating room area because they couldn't come to me, I needed to go to them. I also had a fascination of the clinical side of medicine, and I spent a lot of time taking call with the surgical ICU attendings, the acute pain, the chronic pain, the anesthesiologists, and so forth. So long before I got trained in lean and operational excellence and all those other modalities, I quickly learned that in order for me to know what I know today, I had to have big eyes, small ears, big eyes, big ears, and a small mouth in order to be able to learn. And informally, we were together as a clinical team, and myself as administrators were able to go to administration at the executive level and advocate for a great many things at a time when we had financial constraints. Namely, we needed capital equipment that was to the tune of $2 million. But I share this because early on, I always saw the benefits and the results. In order to advocate for patients was to advocate for the care teams and embed yourself with them to learn. So this really resonates with me because over the 25 plus years after that, I work with a lot of people in administration who were quick to blame the people, label people, silence people. And when I talk people, we're talking workforce right up to the physician that provides the care. So the new agreements in healthcare, I learned about this past summer. My position was downsized during COVID in 2020, and I did consulting. And I've done consulting over the years as an independent contractor for firms. And I had an engagement in 2021 where I thought about maybe I would leave healthcare altogether, but it was actually that engagement that inspired me to dig my heels in and do my own thing. And the reason I say that is because when you often perform consulting work in a team, no different than in an organization that employs you, somebody else sometimes scopes the work. Somebody else might do the root cause analysis and the assessment. And that was the case for me in 2021, where I was just asked, go in and do this change management model. Go in and implement this. We did the root cause analysis, we got it. And we actually came up with a workflows. You just need to go in and implement, almost as if it was a plug and play. But needless to say, it was a 600-bed hospital. During COVID in 2021, 40 plus cardiologists, nurses, and whatnot, a very, very large practice. When I got there, I discovered that, in fact, the root cause analysis that they did wasn't necessarily accurate. And so the workflows that they wanted me to implement philosophically was troubling to me. So I've embarked on, in addition to the training that I have, I do a lot of consulting right now, going in and doing assessments and so forth. I was driven and attracted to this model with David Dibble because it speaks a lot of language that I do, and that is working from the frontline workers from the bottom up with soft eyes, with love and compassion, and understanding what their pain points are and how we could fix it. So the 4 key elements are finding your higher purpose for work, growing and serving your people as leaders, facilitating the tools, 7 tools, and practicing a little bit every day. When we talk about top-down versus bottom-up transformation, which many organizations in healthcare tend to be top-down versus bottom-up, the staff are less engaged, the culture is often demoralized, employees feel the employees are actually perceived as part of the problem versus the solution. They're often silenced. People aren't asking them for their opinion. So there's a lot of oppression. The root cause discovery is often impossible for that reason. Opportunities and ideas are often missed, so there's less creativity and innovation. Little flexibility. Succession planning, if you can imagine, is difficult because when you're not engaging the workforce, it's hard to identify who your next leader is going to be. People make excuses and mistakes constantly. Stress levels are high. It's symptom focused, and everybody knows that today healthcare is riddled with firefighting. Everybody puts out fires based on the symptoms, but no one really gets to the root cause. And so the staff feel oppressed and underappreciated. So David Dibble developed this program called the New Agreements D3D Systems Management Process based on Nobel Prize winning law of dissipated structures. And the science behind this is that well-designed systems have a balance of inputs and outputs, and the system is stable and the emotional well-being, in this case in the healthcare, the workforce is healthy. But when we attempt to push the system beyond what it's capable, what it's designed, what its capability and its capacity is, the system becomes highly stressed. The people are stressed. Quality decreases, efficiency decreases, and the cost increases as well. We have a high level of emotional stress. We look at healthcare today with the tsunami, if you will, of what's going on with the pandemic. We have a lot of high turnover of physicians, nurses, and others, and we have deep moral injury. In the meantime, what do people do? They create, I'm going to go to the next slide. So systems resist change as long as possible. Most people don't like change. They resist change. That's natural. So when a system is at its highest stress level, we have high degrees of variation. We have the risk of harm increases, our volume decreases, our outputs drop. Disruptive behavior is not uncommon, and it doesn't take much extra strain to reach the tipping point. Any additional input, which is what we see right now in healthcare, is going to stress the system. And we have highly disruptive behavior, which we have today in healthcare. So what do people do? They naturally create workarounds. Workarounds don't often solve the problem. More often they don't, and it's certainly not sustainable. We often have patient harm, but we also have employee harm. We have nurses, we have others, respiratory therapists and doctors. Incredibly sad stories of the harm that's being enforced upon the workforce, given the high volume and the shortage of staffing that we have. And the costs are exorbitant. They're continuing to increase. A lot of that has to do with the labor, the contract labor that we have for even locum physicians, let alone the travel nurses that we have, and it's still not enough. So in the worst case scenario is when the tipping point is reached, all bets are off. Capacity to absorb the strain is gone. Systems can collapse with high energy and sudden profound impact, and not much can be done. I don't want to say that we're there yet with healthcare, but we have some systems who are, and we have some that are imminently close to closing. We have a lot of health systems in the country today that have temporarily shut down services and on diversion, or they're taking in patients, stabilizing them, then sending them to another hospital. But in some instances, we've actually had hospitals shut down, and shut down with very little notice, particularly in rural areas. And all of that is due to capacity and the staffing shortages. So when we look at in this system, if you take the systems approach, and I'll talk to you in a minute about the model and how in which we do that, but the new system that emerges isn't the old system making it better. It's actually creating a new system, will accommodate the prior demands in a new steady state. The system will function better, and it's almost always a better experience because the emotional stress levels have dropped for those working in the system. So the new inputs are balanced with the outputs to create a new system, and there's emotional healing. So one of the best outcomes of this is, aside from the fact that you have a system improvement, but more importantly, you have a people improvement. And when you have a people improvement, you have a much healthier workforce. So change is not optional. Whether we choose to be proactive is. And this is a quote. Rick Van Pelt is an anesthesiologist from Brigham and Women's in Boston. And with his permission, coming slides. The slides that I just used, I used with his permission. So Rick was a fellow that on his own time for the course of 2+ years traveled with David Dibble throughout the country to learn this model. He's now the vice president and chief clinical transformation officer at University of Alabama, Birmingham, where he has a very, very robust team of people that train in this model. It's a train the trainer program. And in the first quarter of 2022, they will be publishing their outcomes. So current pain points for the front line, there's a lot of pain points in healthcare, even pre-pandemic. So I want to also point out that the pandemic has certainly maybe the straw that broke the camel's back, but healthcare systems have been troubled for decades. But right now we're focused on nurse and physician burnout, PTSD, nurse and physician shortages. We're focusing on that, but it's actually all of the frontline workers, right down to the people who are reception and schedulers and the greeters for the patients. Quality of care is of concern, as well as patient access for the reasons that I described before in terms of access that is now limited or eliminated. Safety. And then also one of the pain points is the division between the administration and care teams and misaligned. There's often an us against them kind of mentality. And so with that, even prior to the pandemic, a lot of people on the care teams kind of give up the fight per se, and it troubles me that we have this fight in healthcare, and that's persistent and seems to be worse. So I use this slide that David Dibble allowed me to share, Rail Transformation Fast, when he switched this model into the healthcare space in early 2000. This is an example from 2005 where he was working in a large system on a nursing unit, and the turnover rate was 27% before they started to transform with the systems-based training. And then after a year, it decreased to 16%. And then after 2 years, it went to 9%. So there is proven data out there, and I'm anxiously awaiting the data from University of Alabama, Birmingham to be able to share with you all as well. But I want to go back actually to make a point is that when you do this work, even in a large organization, you start small. It grows organically, meaning that when you look at efforts that have been done in other places where you call it a project and you have a consulting firm come in and it's train the trainer for lean and whatnot, people get tired of that. There's a lot of eye rolling and so forth, and they're forced, teams are forced, and people are assigned to particular roles. And this is a very, very different approach. The success, I can speak for the University of Alabama, Birmingham, is such that there's been, even with the pandemic, joy restored to the workforce in medicine in particular areas, to the extent that they're pressed with other departments and other clinical areas wanting the team to come in and help them and do the train the trainer, because they see the joy and the emotional transformation. And that's what makes this different, is that this model focuses on the emotion of the workforce, and that's key. So the game changer in the new agreements D3D model is again, I can't reinforce enough, it's a system-based management process model and focuses on the systems and not the people. The 7 steps really quickly are disruptive discovery. This is key. It's the first thing that you do with a kickoff, and it's gathering the emotional data. It's literally taking the exact words of the voice of the frontline workers and listening to their pain and what it is that they view as the pain points. Then distilling those pain points and grouping them again with the voice of the workforce and grouping them into like type energy together. Defining, choosing the 20% as the 80-20 rule, 20% of a systems to fix that will reduce 80% of a stress. And then right actions in sequence. It's choosing what action to take, who's going to be accountable for that action, what's the right sequence, and then what's the completion date. And then step 5 is real-time reporting and communicating. And it's a short capture of all the salient points that we record step by step with the history of the progress and making sure that we're communicating it to all the members of whatever team has assembled and all the key stakeholders. And then right measurement. Of course, we need to measure. Measuring the 20% of the variables contributing to the 80% of the value. And then the new agreements facilitation. Again, this is a train the trainer model. And I reinforce the strategy being a pull. It's not a directive where you're telling people what to do. You're pulling people along, but in their voice. They are helping you identify what the solutions are to some of these root cause problems that are causing 20% of the pain. It's a participation on a team should be voluntary. This is also very different for healthcare in particular. Where you might start off, let's say, on a unit with nurses. And again, right now with COVID, it's not something we can speak to it later, but we're not able to be in hospitals right now and pull people off the line, so to speak. Some of this work is actually being done remotely initially, but you might start with a handful of nurses. You might start with 5 for a wide variety of reasons, and you're looking for people to volunteer to participate. So in summary, when we talk about when leaders use the system tools, 3 critical things will happen. I talked earlier on, we talk about new leaders and managers emerge. These are the frontline people that participate in the 80-20 rule. Again, when you give the frontline workers an opportunity to let down their guard per se and be honest and be listened to and let their voice be listened to with no threat, no retaliation, with mutual respect and engagement, you'll find that not only will they be enthusiastic and feel appreciated, but you'll also find that the leaders above them will discover that we have leaders amongst this group. And that as servant leaders, you grow and you serve your people through masterful leadership, which is very important. And you create a culture where everyone is trusted and respected. Thank you.
Thank you so much, Anne. We have space for 1 judge at most ask questions. If any. Anne, Doreen, or Vince, you can go ahead.
Okay, sure. Let me ask you very quickly. The systems thinking has been a very well-defined approach in past. So what's something unique you bring on table when you talk about system-based transformation? What's like the core secret sauce? Like with Accenture, so all these big 5 have never seen through. What is the breakthrough you are bringing?
Well, so the approach with this model is, again, it's bottoms up. And again, we're focusing on healthcare, which has often been, even with a systems approach, it might be top down. And this is engaging hospital. And I'm going to use hospital health systems, for example. So the word systems is used a couple of ways here, but it's engaging the frontline workers where the care is provided, as opposed to often in healthcare, we've had executive leadership decide that, well, we need to cut costs and we need to increase our efficiency. So they come up with, let's say, a lean operational excellence model. This starts from the bottom, where we aren't coming in with any preconceived notion of what those root causes of the pain points are going to be, because we want to hear it from the frontline workers. So it takes a health system, if we look at a health system, to be able to be brave and courageous and partner with us, with them, with the care team, to be able to allow for that honesty and identify the opportunities.
Okay, I'll talk offline on the detail about this, because that reminds me of Nest model, or a model where you actually approach a customer from a startup standpoint rather than doing feature first, right? Rather than in a closed room with 4 founders saying these are the 4 features versus. So we'll talk offline since we in the interest of time. So thank you.
Yes, thank you.
Yeah, I'm just thinking that I'm not sure if you have even a team slide. I'm not able to recall. And I'm just trying to see who is on your team.
Right now I'm actually independent, but I have teams of people throughout the country that are all independent in their own firms. David Dibble, I mentioned his name. He is the key principal behind this, and he is the mentor and coach for this particular program, and he is actually facilitating the teaching for new people coming into this program.
Fantastic. Thank you very much.
Thank you.